Good morning. I am Dr. Mary Rose Payan. This lecture will be on ocular pharmacology. At the end of this lecture, you should be able to discuss the various ways in which drugs act on the eye and adnexae, discuss the diagnostic and therapeutic uses of ophthalmologic medications, and discuss the effects of systemically administered drugs to ocular function. Ophthalmic drugs can be delivered locally or systemically. Local administration of ophthalmic drugs can be done through topical administration, periocular administration, intracameral administration, and intravitreal administration. Eye drops, including suspensions and solutions, are the most common types of ophthalmic drug delivery. Systemic administration includes oral, intravenous, and intramuscular administration. For this lecture on ocular pharmacotherapeutics, we will be talking about diagnostic drugs and therapeutic drugs for the eye. We will have cases that will demonstrate the need for diagnostic drugs such as local anesthetics and mydriatics and mydrialytics. Case 1 is a 24-year-old male who consulted for foreign body sensation on the right eye. 3 hours prior to consult, while welding, the patient experienced foreign body sensation on the right associated with slight blurring of vision and eye redness. On slit lamp examination, there was note of a foreign body on the corneal surface of the right eye. Assessment was corneal foreign body (OD) and the plan was for removal of corneal foreign body. Topical anesthetics such as proparacaine and tetracaine are needed in suppressing corneal sensitivity during ophthalmic procedures. The onset of action is fast, around 10 to 20 seconds, although the duration is short, around 10 to 20 minutes. Longer procedures in the clinic may need reapplication of topical anesthetic. For topical anesthetics, as well as for most ophthalmic eye drops, there is a mild burning sensation that immediately follows instillation, and this can last for about 10 to 30 seconds. Patients should be warned of the mild burning sensation prior to installation so as not to cause unnecessary alarm. Another important side effect to know is that chronic use of topical anesthetics may cause corneal desquamation. This is the reason why topical anesthetics are not prescribed to patients as home medication. In some countries, fluorescein dye is combined with proparacaine as a topical anesthetic that can be used to stain the eye for diagnostic procedures like applanation tonometry. Fluorescein can also detect break in the corneal epithelium. While this preparation is not available in the Philippines, a drop of proparacaine can be placed on a fluorescein strip before applying to the eye to get the same effect. Case 2 is a 60-year-old female diagnosed with uncontrolled diabetes mellitus for 12 years. She consulted for blurring of vision on both eyes, right greater than left, and needed a retina exam. Before you can do indirect ophthalmoscopy, you have to first dilate the pupil. Pupillary dilation is controlled through the autonomic system, which consists of the sympathetic and parasympathetic pathway. Two opposing muscles in the iris, the sphincter and the dilator muscles, are under the control of the autonomic nervous system. The sympathetic pathway leads to the dilator muscle of the iris, while the parasympathetic pathway leads to the sphincter muscle of the iris. Mydriatics and mydrialytics act on adrenergic receptors of the autonomic nervous system. Mydriatics and mydrialytics act on the sympathetic nervous system. The mydriatics are adrenergic agonists or sympathomimetics, while the midriolytics are adrenergic receptor agonists or anti-adrenergics. Mydriatics like phenylephrine and cocaine dilate the pupil, while midriolytics reverse the action of the mydriatics and constrict the pupil. Cycloplegics act on cholinergic receptors. They are cholinergic antagonists or anticholinergics, which denotes their mechanism of action to stop the effects of acetylcholine by binding to and inhibiting cholinergic receptors of the parasympathetic pathway. Tropicamide, atropine, homatropine, cyclopentolate, and scopolamine inhibit the pupillary sphincter muscles, which causes mydriasis or pupillary dilation and inhibits the ciliary body. Tropicamide is considered clinically the drug of choice for routine dilation because it has the fastest onset and shortest duration of action, meaning it quickly gets your patient dilated and its dilation effect quickly wears off. Cyclopentolate is the drug of choice clinically for routine cycloplegic refraction because it provides for a faster cycloplegia with less residual accommodation. It is often used for pediatric patients and certain patients with accommodative disorders such as accommodative excess or accommodative spasm. Atropine is the most potent mydriatic cycloplegic available. It is directed for use when complete cycloplegia is required. Because of its potency and long duration of action, it is not routinely used for dilation. Atropine is indicated in cases of suspected accommodative esotropia and for amblyopia treatment. The resulting blurred vision caused by atropine can also be used in amblyopia therapy as a form of penalization of the eye with normal visual acuity. Penalization combined with optical over or undercorrection is an alternative to direct occlusion of the better eye in amblyopia therapy. So to compare the three different cycloplegics, atropine is considered a long-acting cycloplegic with duration of action lasting for about 7 to 12 days. Cyclopentolate is an intermediate-acting cycloplegic with duration of action lasting for about 24 hours. And tropicamide is a short-acting cycloplegic with duration of action lasting about 6 hours. Let's now go to the therapeutic drugs. We will be talking about analgesics, ocular hypotensives, anti-infectives, anti-inflammatories, anti-allergy and ocular decongestants, and preparations for ocular surface disease. Case 4 is a 55-year-old male consulting for right upper lid mass of 2 months duration and described as a rapidly progressive hard mass. Biopsy was suggested and post-biopsy, patient complained of pain on the operative site. Local anesthetics act on the cell membrane to produce completely reversible conduction blockage of nerve impulses, resulting in sensory anesthesia and skeletal muscle paralysis. The use of local anesthetics has become an important aspect of pain management in surgical settings. Elective outpatient surgeries such as tissue biopsy cause minimum tissue disruption and are short in duration. As a result, local anesthetic agents are a major component in the intraoperative and postoperative pain control. The most commonly used local anesthetic agents are lidocaine and bupivacaine. Lidocaine acts faster within 2 to 5 minutes of injection and for this reason is often favored in outpatient settings for pre-incisional injection. However, its effect only lasts up to 2 hours without epinephrine and 3 hours with epinephrine. On the other hand, bupivacaine has a slower onset of action, about 5 to 10 minutes after injection, but its effect lasts much longer for about 4 to 8 hours. The delay in onset of action makes it a less popular option as a primary source of local anesthesia. Given the longer duration of anesthesia offered by bupivacaine, giving it preoperatively in elective surgeries together with lidocaine offers a more effective postoperative pain control compared to using lidocaine alone. Pain signals are conveyed to the brain through the trigeminal nerve. The trigeminal nucleus sends pain signals to the somatosensory cortical areas of the brain. Analgesics may act as peripheral acting agents such as nonsteroidal anti-inflammatory drugs, or NSAIDs. NSAIDs are the most effective and safest for short-term use. Together with other non-opioid analgesics, NSAID inhibits the cyclooxygenase pathway for pain and inflammation. Opioid analgesics possess morphine-like analgesic effects and are the first drug of choice for treatment of severe acute pain. Analgesia is produced by binding to various opioid receptors in the brain, brainstem, and spinal cord, thus mimicking the effects of endorphins. The amount of analgesia produced is directly proportional to those with no ceiling effect, thus the potential for abuse and addiction. Case 5 is a 35-year-old female who consulted for sudden bilateral blurring of vision while watching a movie and associated with sudden pain and eye redness on both eyes. Glaucoma is characterized by a particular pattern of progressive damage to the optic nerve that generally begins with subtle loss of peripheral vision. Elevated pressure in the eye is the main factor leading to glaucomatous optic nerve damage. There are two types of glaucoma: open-angle glaucoma and angle closure glaucoma. Glaucomatous optic nerve damage is irreversible, so the goal of treatment is to decrease intraocular pressure to control or retard progression of optic nerve damage that leads to visual loss. Eye drops are often the first choice for treating glaucoma patients. Eye drops used in managing glaucoma decrease eye pressure by helping the aqueous to drain better and/or decreasing the amount of aqueous made by the eye. Glaucoma medication includes beta blockers, cholinergic stimulators, adrenergic stimulators, carbonic anhydrase inhibitors, prostaglandin analogs, and hyperosmotics. Drugs to treat glaucoma are classified by their active ingredient. Prostaglandin analogs like latanoprost, travoprost, and bimatoprost increase uvuscleral outflow. Beta blockers like timolol and betaxolol decrease aqueous humor production, and adrenergic agonist or alpha agonist like apraclonidin and brimonidin decrease aqueous humor production and increase uvuscleral outflow. Carbonic anhydrase inhibitors like dorzolamide, brinzolamide, and acetazolamide in oral or topical form decrease aqueous humor production. Cholinergic agonists like pilocarpine and carbachol increase uvuscleral outflow. Case 6 can be represented by either an 11-year-old male consulting for periorbital swelling on the left or a 60-year-old male consulting for blurring of vision on the left. Both cases are infectious diseases that need to be treated with anti-infectives. We will be discussing antibacterial, antiviral, and antifungal. Topical antibiotics are used to treat bacterial conjunctivitis, blepharitis, keratitis, external hordeola, and endophthalmitis. Topical antibiotics can also be used prophylactically to prevent infection before and after ophthalmic surgery. Treatment is usually empirical, and topical agents should be active against most likely pathogens, namely Staphylococcus aureus, coagulase-negative staphylococci, streptococci, Haemophilus influenzae, and coliforms. Infection with Pseudomonas aeruginosa is less common. There are 5 ways by which antibacterials fight off microbial infection. Penicillin, cephalosporin, bacitracin, and vancomycin attack the structural integrity of bacteria by inhibiting cell wall synthesis of peptidoglycans. Polymyxin B and gramicidin attack the structural integrity of bacteria by disrupting bacterial cell membranes. Aminoglycosides, tetracyclines, microlides, and chloramphenicol inhibit bacterial protein synthesis by binding of drug to bacterial ribosomes. Sulfonamides, pyrimethamine, and trimethoprim attack the structural integrity of bacteria by inhibiting folic acid synthesis. Fluorinated quinolones attack the structural integrity of bacteria by inhibition of enzymes DNA gyrase and topoisomerase 4. There are 3 viruses that can cause ocular disease: herpes simplex virus, adenovirus, and cytomegalovirus. Of these 3, only herpes simplex virus has antivirals that are approved for ocular use. Acyclovir, valacyclovir, famciclovir, and ganciclovir interfere with viral replication and multiplication by inhibiting thymidase kinase needed for nucleic acid synthesis. There are 4 kinds of antifungals, none of which have been approved in the Philippines for ocular use. Polyenes like amphotericin B and natamycin increase cell permeability by binding ergosterol in the cell membrane. Pyrimidines like flucytosine inhibit DNA synthesis by blocking thymidine kinase. Azoles like ketoconazole, miconazole, itraconazole, fluconazole, and voriconazole increase cell permeability by binding ergosterol in the cell membrane. Echinocandins weaken the cell wall by inhibiting glucan synthesis. K7 is a 25-year-old female consulting for blurring of vision. 1 week prior to consult, there was sudden blurring of vision associated with eye pain, halos around light, and photophobia. On slit lamp examination, there were inflammatory cells in the anterior chamber, making a diagnosis of acute anterior uveitis on the right. Anti-inflammatories like corticosteroids, NSAIDs, and cyclosporin inhibit the inflammatory prostaglandin pathway. Corticosteroids suppress inflammation and can be short-acting, intermediate-acting, and long-acting. Anti-inflammatories can be given as topical administration, local injection, or systemic administration. Examples of topical anti-inflammatories are prednisolone acetate, dexamethasone, flumetazone, and loteprednolone. Examples of oral injection are triamcinolone and methylprednisolone. Systemic anti-inflammatories can be in the form of oral or intravenous administration of prednisone, methylprednisolone, and dexamethasone. Case 8 is a 10-year-old male consulting for bilateral on and off eye itchiness associated with eye redness and swelling. On eye exam, there were papillae on the palpebral conjunctiva of the upper lid and trantus dots on both eyes. A diagnosis of allergic conjunctivitis was made. Anti-allergy can be antihistamines like nafazolin and levocabastin, or mast cell stabilizers like olopatadine and cromolyn. Decongestants like phenylephrine, nafazolin, oxymetazoline, and tetrahydrozoline improve the eye redness associated with ocular allergy. Decongestants are synthetic adrenergic agonists that cause conjunctival vasoconstriction. Long-term use is not recommended because of the risk of rebound congestion. Topical antihistamine like olopatadine is the first-line drug for symptomatic relief of allergy. Antihistamines inhibit the inflammatory prostaglandin pathway, which then inhibit the action of histamine. Mast cell stabilizers like cromolyn sodium and ketotifen inhibit type 1 immune response, thus preventing mast cell degranulation. Case 9 is a 35-year-old male who consulted for tearing of both eyes associated with eye pain and foreign body sensation. A diagnosis of tear film dysfunction was made. Tear film dysfunction or dry eye syndrome is a common and complex condition affecting the ocular surface. The health and normal functioning of the ocular surface is dependent on a stable and sufficient tear film. Ocular lubricants used for dry eye syndrome are available in a variety of formulations. Ocular lubricants like polyethyl glycol, hypromellose, and methylcellulose often contain preservatives like benzalkonium chloride. Drugs for ocular surface disease can be classified into four types. Artificial tears like methylcellulose and propyl glycol reproduce metabolic, optical, and physical characteristics of natural tears. Non-medicated ointments like petrolatum create a lipid layer that retard evaporation. It can be used for moderate to severe dry eye, exposure keratopathy, or severe corneal epithelial compromise. Secretagogues like cholinergic agents stimulate lacrimal gland function to enhance tear production. Anti-inflammatories like corticosteroids and cyclosporin suppress cytokine and receptor-mediated inflammatory process of the lacrimal gland. This is the end of the lecture. Thank you for listening.